Great, hello. So I'm glad to be able to give a brief talk at this session in honor of Dave Ilsen. So I'm going to speak about the role of modern radiation in esophageal cancer. I was asked to speak to some hot button topics like protons and the Abscopal effect, and in a sense that's sort of an easy talk because there's very little data for any of that. But seeing as how most people here are not radiation oncologists, I'm going to speak a little more broadly about what we're doing these days with radiation therapy in esophageal cancer. And that's really the focus, as you could tell from the panel, for gastric cancer, radiation increasingly has a fairly marginal role. But these are my disclosures. Thought it'd be interesting just to kind of put things in perspective. As a radiation oncologist who treats esophageal cancer, I'm quite mindful of the significant toxicity that my treatment inflicts on patients. This is Christopher Hitchens, a noted writer and intellectual who suffered from esophageal cancer and passed away. He actually, speaking of proton therapy, received protons at MD Anderson. And here he is quite vividly describing his experience. For the sake of time, I'll just kind of skip to this bolded part where he says, if I had been told about all this advance, would I have opted for the treatment? There were several moments as I bucked and writhed and gasped and cursed when I seriously doubted it. And so he ultimately succumbed to the disease. And, it's worth noting that for all the hoopla that come with protons, protons are not going to do anything about this because, of course, this is entirely related to the effect of the radiation on the esophagus itself. So protons would have no bearing on that. But that being said, of course, we persist and we recommend radiation to many patients with esophageal cancer because there's clear benefits. And as you've heard already, for esophageal and GE junction cancers, the CROSS trial demonstrates that chemoradiation improves survival and prevents local recurrence, certainly compared to surgery alone. And we also know that for patients who cannot undergo surgery due to medical inoperability or if they have a proximal tumor, that radiation combined with chemotherapy then becomes the definitive therapy. For gastric cancers, although there is a benefit to post-op chemoradiation compared to surgery alone, as we've discussed, increasingly the approach now favors chemotherapy alone and using radiation quite selectively. So several speakers have already mentioned the CROSS trial, again, which after a series of smaller and kind of conflicting trials, this trial really conclusively demonstrated that pre-op chemoradiation improves survival compared to surgery alone. And that the benefits were seen in both adeno as well as squamous cell cancer, although obviously the benefit is significantly greater in the squamous population. And one of the questions we think about, of course, is how much of the benefit is due to radiation, how much could be achieved with chemotherapy alone. The POET trial addressed this question directly, randomizing patients either to pre-op chemo or pre-op chemoradiation for GE junction adenocarcinoma. This study was recently updated. The issue with this trial was that it fell short of accrual and closed early, and so it was underpowered. The initial report showed a trend towards survival benefit with radiation. On the long-term update, it's still not quite statistically significant, although the p-value got pretty close, as you can see. And radiation certainly was observed to improve local progression-free survival. So I think this is a fairly good indicator that the radiation certainly is adding to the benefit that you get from chemotherapy. And then with respect to definitive chemoradiation, this is now a historic but still relevant trial of chemo versus chemoradiation. Of radiation alone versus chemoradiation, demonstrating that about 1 in 4 patients were able to achieve long-term survival with chemoradiation. Radiation alone had no long-term survivors. Now, the big problem with this approach, of course, is that local failure or local persistence is still quite high. So nearly 50% of patients either don't have a complete response or develop a local failure. And you can see the incidence of this by the time you get to about 2 years out, nearly half of patients have local failure. So really want to just put everything in context by asking how we can improve outcomes with radiation therapy. Broadly speaking, there's 2 approaches. One is you can improve the tumor-directed efficacy of the radiation itself. Some ways that one might try to do this could be by increasing the radiation dose, by optimizing the choice of concurrent chemotherapy, and developing novel radiosensitizers, and we could put immunotherapy in that category. The other way to increase the therapeutic ratio would be to decrease the toxicity from radiation, and this would entail trying to identify and mitigate some of the predictors of radiation-related toxicity, trying to define rational field designs so that you don't have to expose as much normal tissue to radiation. And in that context, we'll talk about newer technologies like IMRT and proton therapy. So when it comes to whether we can improve outcomes by increasing the radiation dose, basically the answer is this is not helpful. The successor trial to the RTOG 8501 trial was the intergroup 0123 trial led by Bruce Minsky, and this compared high-dose chemoradiation to standard chemoradiation. This was a totally negative study, no benefit to high dose. It was a little peculiar because there were a lot of toxic deaths in the high-dose arm, but that couldn't really be attributed to the high dose because most of those people died before they even achieved 50 gray. Nevertheless, there's no evidence from this trial that a higher dose is helpful. It's worth noting that there was actually a recent Chinese trial in squamous cancer patients that was reported in abstract form, similar, randomizing patients to 50 versus 60 gray, and again, showing no benefit to radiation dose. And this is, somewhat painful for radiation oncologists to look at this and wonder what, so is the radiation dose meaningful at all? Of course we have to assume that it does matter, at least in theory. The issue with the esophagus as well as, GI tumors in general is that we're really limited in how high of radiation dose we can deliver, given the inherent toxicity that's associated with radiating the luminal GI tract. Certainly from the lung SBRT experience, which is another disease that I treat, we do know that if you crank up the radiation dose high enough, you'll eventually overcome radioresistance, but those levels of radiation dose are simply not achievable in a safe manner in esophagogastric cancer. So, probably within the realm of what is safely achievable, these types of differences in dose from 50 to 60 gray are unlikely to really move the needle much. And, it's been observed that the path CR rate with chemoradiation is hovering around 20 to 30%. And you see that pretty consistently regardless of, what type of radiation, exact radiation dose is used. So it really suggests it's the underlying heterogeneity of the tumor biology that's driving the radiosensitivity. So can we improve the response to radiation other than increasing the radiation dose? Well, certainly the fact that radiation alone is not particularly effective suggests that it's crucial to identify the optimal concurrent chemotherapy agent. We've already heard from Dr. Goodman about the CALGB 80803 trial, which suggests a very promising role for using PET scans to direct the selection of chemotherapy agents. Just briefly to talk about the attempts to combine targeted agents with radiation, the various trials that have been done essentially have been all negative. These have been generally in unselected patients, which probably explains why you're not seeing any signal, but nothing for EGFR-directed or VEGF-directed therapies. We've also heard about HER2. So now this, we're hopeful that the story will be different because there is a randomized trial that has closed, and we're expecting results to be reported probably within, I would assume, the next year or so. For this, we have a target. This study selected only patients that had HER2 overexpression, and randomized patients either receive standard pre-op chemoradiation with or without trastuzumab. So hopefully we'll see results from that soon. So to touch on immunotherapy, so as we all know, immunotherapy is a very exciting development, and particularly combining immunotherapy with radiation, and that's rapidly changing the management of many cancers, and in particular locally advanced lung cancer, in which the PACIFIC trial has demonstrated a survival benefit now with the use of essentially adjuvant immunotherapy after concurrent chemoradiation. So certainly there's a lot of interest in doing this in esophagogastric cancer. Dr. Koo leading a trial combining immunotherapy with pre-op radiation in esophageal adenocarcinoma here. And the abscopal effect, as you're probably aware, refers to a phenomenon where radiating one tumor seems to induce an immune response that then leads to regression of other tumors in the patient's body. And this is hypothesized to be due to tumor antigen release from the focal radiation therapy that is now priming the immunotherapy effect on non-irradiated tumors. And sort of the seminal case report came from MSKCC. This was in the New England Journal in 2012, in a case in which a patient with metastatic melanoma who was being treated with ipilimumab received focal radiation, SBRT to one metastasis, and then subsequently developed a complete response in other sites. So there has, to my understanding, been a single report that I was able to find of the abscopal effect in esophageal cancer. This was recently published in a case report of a 65-year-old man with metastatic squamous cell cancer. He received 4 cycles of standard chemotherapy and then was put on standard pembrolizumab. While he had been on pembrolizumab, he developed recurrent lymph node metastases in the retroperitoneal and pelvic lymph nodes. And so a decision was made at that point to give him a break from systemic therapy and give him SBRT in the form of cyberknife therapy to the retroperitoneal lymph node. So that's this one right here. And this is the FDG avid pelvic lymph node. This middle panel is the radiation plan using cyberknife 42 gray in 6 fractions. And 2 months later, not only was the radiated node found to have developed a complete metabolic response, but also the pelvic lymph node completely regressed. Now, these are very exciting anecdotes, and certainly there are ongoing trials, including here in colorectal cancer, where we are actually trying to elicit this type of effect. What remains unknown, though, is how frequently this actually happens, and in all likelihood, it's really quite rare, and whether we can do anything in particular to elicit the effect. There is a sense that giving high doses of radiation per fraction may be more likely to induce it, presumably by being more likely to cause tumor lysis and antigen presentation. But again, there would be limitations to how high of a dose per fraction one could give for esophageal and other GI luminal cancers. So the other side of the coin is trying to reduce the toxicity that's associated with radiation. There's no doubt that radiation can have a very strong tumoricidal effect, and if there were no downside, then we would use it all the time. But this, of course, is mitigated by toxicity that's related to the effect of radiation on normal tissues. And esophageal cancer is a particular challenge because traditionally we've used radiation fields that are significantly larger than the tumor itself, and this is just a diagram of a traditional radiation field in which you can see that the radiation field right here is significantly larger than the actual tumor. So, one approach to optimizing outcomes of the radiation is to have a more rational and data-driven and standardized approach to defining the radiation field. Esophageal cancer is somewhat unique in the sense that it spans effectively 3 anatomic sites. You have the neck, the thorax, and the abdomen. And so there's really just a lot of potential for inconsistency and a lot of particular tumor presentations in which there'd be a lot of questions about how to contour it, especially in this era of highly conformal radiation techniques. And so this is work that Dr. Goodman and I did actually to generate a expert contouring consensus atlas to try and define the optimal radiation field. And this now is used as a reference for ongoing clinical trials. So, what else can we do to try to optimize the therapeutic ratio? So, again, calling on the experience from non-small cell lung cancer, there is recent data suggesting that normal tissue dose is strongly correlated with survival. And in particular, the finding from the RTOG 0617 trial, which is a study of concurrent chemoradiation for stage 3 lung cancer, indicated that it was really the heart dose that was strongly correlated with survival. We're treating the significant part of the thorax and heart for esophageal cancer, so this prompted us to ask the question, would we identify the same association here. This is just a diagram from one of several data sets in lung cancer showing that heart dose correlates with survival. So this was, we undertook an analysis of nearly 500 of our patients who received chemoradiation for localized disease, both in the pre-op as well as definitive settings, analyzed multiple metrics of lung and heart dose, including the mean heart dose, the mean lung dose, but also a parameter called Vx, which basically is where X, basically the volume of the organ receiving a given dose. So for example, the lung V20 would be the percentage of the lung volume that's receiving at least 20 gray. And then we looked to correlate to survival. And this diagram shows you the radiation dose. This is the radiation dose distribution for 20 gray. So the red line would be our treatment volume. And so this would get 50.4 gray. But obviously, radiation gets deposited as well along the radiation beam path. And so here you can actually see this is the actual volume that gets 20 gray. And so you can see that a fair amount of lung as well as heart gets 20 gray. And so what we found and reported at GI ASCO was that indeed both heart and lung dose were correlated to survival. But what was somewhat surprising to us was that after we adjusted for everything, it was really the lung dose, and in particular we selected this parameter lung V20 as a strong predictor of survival, and stronger than heart, which actually fell out of the multivariate analysis. And we've actually done further analyses on these to try to look at, look not just at survival, but at disease recurrence. And so what we've actually found is that lung dose actually, even though it correlates with survival, it doesn't correlate with local recurrence or distant metastasis. So, by inference, it strongly suggests that the association with survival is due to non-cancer related death. So, that really leads me to the last part of the talk, which is if we can improve the outcomes with radiation by minimizing normal tissue dose, minimizing toxicity, how can we do that? So what we use routinely, although it's not necessarily the standard around the world, is intensity modulated radiation therapy, which essentially is a way of dynamically shaping multiple radiation beams. So whereas standard radiation uses fixed beam shapes, IMRT uses computer-controlled beam shapes that actually the shape of the beam is changing while the beam is on, and this allows you to achieve very complex radiation dose distributions and essentially kind of paint radiation dose to map well to complex targets and also avoid normal structures. And as you would expect, this does allow one to reduce heart and lung doses significantly. And even though this hasn't been studied in a randomized setting, there are retrospective and population-based analyses that do suggest that you are seeing less radiation-related cardiopulmonary deaths with IMRT. And proton therapy you can think of as a way to become even more conformal with the radiation. Because IMRT, even though it allows you to achieve extremely complex dose distributions with very high accuracy, it comes at the expense of spreading out the sort of scattered dose to a much larger volume. So, if you look here at this IMRT plan, the blue and yellow lines are fairly conformal to the target volume, but then you can see that the lower doses are basically spread out all over the body because the radiation dose, when you're using photons, travels through the patient and then exits. And protons have the characteristic that they enter the patient and then they stop at a given distance, so they don't have that exit dose. And so you can really reduce the amount of low dose spread. The problem, of course, is that even though these pictures are undeniably appealing, we don't have prospective evidence that this dosimetric benefit translates to a clinical benefit. And this is not a trivial matter because proton therapy requires a dedicated facility and is much more expensive. And this was a New York Times editorial. This is actually in 2012 at sort of the beginning of what some people are calling the proton arms race, where you're seeing them pop up around the country and often in pairs because once one group decides to build a proton facility, the other alliance of hospitals realize that they have to keep up with the Joneses. And so in a way, it's shining a unwelcome spotlight on our field because it again raises this question of cost effectiveness. So we do need data, and there is a randomized trial of proton versus photon radiation that is being led by Energy Oncology, which we'll be activating soon. And proton therapy has been available at MSK, or to MSK patients for several years via an affiliation with a facility in New Jersey, but very few esophageal cancer patients have been treated. It's really not something that we would routinely refer for. It's essentially been limited to reirradiation cases where we feel that it's reasonable to do that. There will, however, be a new proton facility in which MSK will be a major stakeholder in this New York Proton Consortium, and this facility, which will be up in Harlem, is slated to open in 2019. So in conclusion, radiation, importantly, with concurrent chemotherapy, is a survival-enhancing therapy in EG cancer. Higher radiation dose and attempts so far to incorporate novel radiosensitizers haven't really moved the needle so far, but we think that immunotherapy and HER2-directed agents in combination may have promise. And decreasing radiation toxicity may be an equally important way to enhance the therapeutic ratio. Reducing the dose to normal tissues, especially the lung, is important. And IMRT and protons and other technological advances can reduce normal tissue dose, may have a benefit, but we're still waiting for prospective validation. So I just want to thank Dr. Janjigian and the Alumni Society for letting me speak, Dr. Ilsen, Dr. Goodman for their mentorship, and all of my colleagues at the DMT. Thank you.